And so now I'm going to share with you that our guest tonight is Jana Briggs. She is going to fill us in on different aspects of substance use and substance use disorder. And so we are so appreciative always, and especially with our relationship with Vanderbilt Behavioral Health. This presentation is actually part of our annual education series that gosh, Tracy, we've been doing this for, well, at least 10 years in partnership with Vanderbilt. And we have always been so appreciative of that. And Jana, it's so nice to bring you into the fold for this. And I am actually going to turn this over to you and let you have the floor and share with folks about yourself and about the information you're going to be bringing us.
Thank you. So I'm going to share my screen and just make sure that it's accurate. Let's see. Okay, can you all see this?
We can.
Okay, perfect. Well, welcome everybody. And I want to say my sadness that Dr. Reed Finlayson is not joining us. He's feeling under the weather, but he created this great presentation. And so I took some notes and I'm really excited to share the information with you. So I work with Dr. Finlayson. I'm the other provider attending on the dual diagnosis unit at Vanderbilt. So we have a 16-bed co-occurring unit where we provide stabilization for individuals' substance use and mental health conditions. And then so just a little bit of information about myself. I'm young, but I've been in the field for about 10 years. I completed my undergraduate as a nurse at Texas Christian University in 2013. And then from there, made my transition to Vanderbilt and worked at the psychiatric hospital as a nurse resident, grew into a charge nurse and then a clinical staff leader, really became passionate about serving individuals with substance use disorder and particular pregnant women that were dependent on opioids and allowing them to become very stable during their pregnancy and help them and baby through that transition. And then Dr. Finlayson and another psychiatrist, Dr. Peter Martin, that some of you may be familiar with at Vanderbilt, convinced me to go back to school so I could make a larger impact on the substance use community. So that's what I did. I really wanted to be able to prescribe Suboxone and a lot of these life-saving medications for individuals with substance use disorders. So I went to University of Washington and obtained my doctorate, graduated in 2020 with a focus on addiction medicine. And then from there, I went and worked at a treatment center for a little bit over 2 years. I worked at the Betty Ford Center down in Southern California, so beautiful place for people in recovery. And I was the first integrated provider there, so providing medical care and then also psychiatric treatment. And I recently returned to Vanderbilt because the team there is just so phenomenal, and I wanted to come back and work inpatient again. And I returned December of last year. So I'm excited to be here. So I will complete the presentation and then we'll be happy to answer questions after. I did take some notes, so I'll look down and ensure that I add to Dr. Finlayson's beautiful slides. So really the focus tonight is going to be on the co-occurring, right? Substance use along with psychiatric illnesses. And what I tell my patients is that there's a reason why we use substances. There's a purpose behind it. And because of that, as you all know, there's a huge prevalence between individuals that have mental illness and then also are diagnosed with substance use disorders. One statistic that's pretty alarming is showing that about 60% of adolescents meet a criteria for a psychiatric illness in addition to being in substance use treatment. And I think this shows us the large predisposing or hereditary factor that there is with substance use disorders. And then below is listed some of the most common psychiatric disorders, and we'll speak about how those are diagnosed without a substance use disorder, maybe precipitated by a substance use disorder, and how they can be potentiated and continue to increase in symptoms if someone is using substances. So I love visuals. This is one graph that really shows the percent of individuals with a severe mental illness and the percent of those individuals that have a substance use disorder. So you can see the statistics are pretty high and they're continuing to rise. And it shows that substance use can definitely contribute to the development of mental disorders and then can exacerbate them, as we know, and we'll go into more specific substances in a little bit. It's a great quote, "Be wary of wastebasket diagnoses." So we view any substance use disorder as a chronic disease and not in a negative light. We want to really ensure that we are aligning an accurate diagnosis with someone with a substance use disorder so that we can align with appropriate treatment. So, one example is we would not say that someone had bone issues when someone breaks their pelvis, right? We really want to dictate what is the problem here so we can find out the appropriate treatment. So it can be a common term to use, maybe when individuals are coming into the hospital, the emergency department, for individuals to say, oh, they're just polysubstance use. But we really want to be very particular about what substances they're using for what period of time so we can accurately figure out the best course of treatment for them. One example I like to give, especially with stimulant use disorders, again, there's a reason why people use what they use. So I find a lot of my individual patients that have stimulant use disorders, which common stimulants are cocaine and methamphetamines, maybe they have untreated attention deficit disorder. And so our patients are very smart. I think individuals with substance use disorders are very intelligent. And so maybe they're treating their ADHD with cocaine or with methamphetamines. So again, it's super important for us to identify what substances someone is dependent on so we can look at the reasons why they've turned to those substances and then maybe treat the ADHD and address the substance that they have become dependent on. So common risk factors for substance use disorders, as we know, substance use disorders and mental health disorders definitely run in families. I use the 4 Ps a lot with my patients. So we look at predisposing factors, reasons for use, precipitating factors, what precipitated someone using substances, protective factors, so what are areas that we can really focus on to help someone in recovery, and then potentiating factors. So what are areas that continue to have a person to use the substances? So a potentiating factor could potentially be an ADHD, attention deficit disorder, that is not being treated. And so that untreated ADHD is potentiating that individual's use of methamphetamines. So here, looking at predisposing factors, we know that there are genetic vulnerabilities and that certain genes may be risk factors to substance use disorders. Also knowing that environmental traumas or environmental factors like stress and trauma can cause genetic chances that are passed down through generations. And again, that's looking at predisposing factors. Even what was mother using when baby was in utero, that's a very important factor. And then environmental factors, so that's mainly precipitating factors. Early exposure to stress and trauma has a huge increased risk for someone developing a substance use disorder. And then the last example, so substance use to cope with PTSD, that's what we would call a potentiating factor. Again, there's a reason we do what we do. I find a lot of times individuals that have anxiety or post-traumatic stress disorder, which can occur for people in numerous ways. It's not just going to combat, right? It's any kind of trauma that someone has experienced and their reaction to it a lot of times causes an activation of their nervous system. And so again, reasons why our patients and why we do what we do, alcohol can be something that can really calm the nervous system in the short term. So it makes a lot of sense to me when a patient comes in with severe post-traumatic stress disorder or anxiety that maybe they developed an alcohol dependency because they're trying to treat their anxiety or their stress. And then unfortunately, as you all know, looking here at the mortality rates from unintended drug overdoses are just skyrocketing throughout the country. One statistic showed that over 106,000 people in the US died from drug-involved overdoses in 2021. And it's even increased, especially since we're living in the post-COVID era. As you can see, one of the steepest lines is the synthetic opioids. One that we're all very familiar with now is fentanyl. Due to its potency, a lot of individuals, unfortunately, aren't aware maybe that they're using fentanyl, and due to its potency, the overdose rate is just so high because the tolerance of a lot of our loved ones is so low. I would also say a reason why we've seen sharp increases in these numbers is the increase in the number of mental illnesses that a lot of individuals are struggling with, and the overall stress in the world, as I mentioned, post-COVID, right? We see with an increase in stress, anxiety, depression, trauma, there's a strong correlation with the increase in substance use. One sad statistic I saw during the pandemic was specifically around registered nurses, and the sharp increase, about 20% of individuals that are nurses in the United States developed an alcohol use disorder during the pandemic, which is staggering. And it also makes a lot of sense to me. The amount of stress, anxiety, trouble sleeping, and the trauma they experience, they try to figure out a way to cope. And so knowing all of this, I love addiction medicine, but there definitely needs to be more research into what are the best treatments for these individuals that are struggling with substance use disorder. More research specifically needs to occur for protective and preventative measures, so we can better identify patterns and really provide that individualized treatments. One study that I saw about 3 years ago looked at two groups of adolescents. And the first group of adolescents had a mother or a father with an alcohol use disorder. And the second group of adolescents did not have a mother or father with an alcohol use disorder. And they did scans of their brains. And what they found, one of the major findings, was the group of adolescents that had a mother or a father with an alcohol use disorder had fewer number of overall dopamine receptors in their brain. Well, what causes a huge release of dopamine in our bodies and our brain? Many substances, alcohol, methamphetamines, cocaine, fentanyl, other things also like food, sex, and gambling. And so this was very telling, because I think for a lot of our patients, they say, why me? Why did I develop, substance use disorder? And why do I also struggle with anxiety or depression? And as we know, there's a huge predisposing factor, and it'd be great if, years from now, or hopefully months from now, but being hopeful, years from now, we can really do more scans to look at what's going on in someone's brain, especially if we know that they have a first-degree relative that has a substance use disorder or a mental illness, so that we can provide more education younger, because we know our loved ones are using younger and younger. And so at least we can give them that education of, here's your dopamine levels, here's your chances that potentially you will develop a substance use disorder, because maybe you have lower number of dopamine in your brain and your body. And so literally you're craving some of these substances, and to know that and really be able to identify suitable treatments of how else do we fill your body and your brain with dopamine besides methamphetamines, alcohol, and cocaine. Let me I have a dog right near me. So that's why it's super important to really spend more time looking at individualized treatments. And so here, looking at the concept of polysubstance use, again, not stigmatizing with regards to someone has an addictive personality, that it's becoming more popular for individuals to use multiple substances, and that they all serve a purpose. Right? That's what we're seeing even in the rate of overdoses. Individuals aren't just solely using one substance. It's becoming a lot more common to use multiple substances, and we'll talk about why that is the case. And then looking at addiction has biological, psychological, sociological, and behavioral components. Is my dog distracting? Should I get that? Is it okay? Sorry. And so looking at the differing conceptual frameworks, so looking at common factors or a gateway, there are a lot of hypotheses out there. I really like to provide individual treatment and really sussing out why people are using the certain substances that they are. And not saying that there is one treatment or one reason why someone developed a certain substance use disorder. A lot of patients ask me, should I stop the use of all substances if my primary substance, say, is alcohol? And again, providing that individualized treatment, the research supports that an individual is more likely not to return to their primary substance if they stop all substances. So say they come to treatment and have dependency on alcohol, maybe cocaine and cannabis. Even though alcohol is their primary, they're more likely to be successful if they stop all three substances. However, instead of just grouping this into you're just a polysubstance user, what we want to really step back with is what's your intention behind using the other substances? Do you use cannabis to sleep or for anxiety? Looking at what's the intention behind it, because if we're very clear on the intention, then we can really look, is this helping the person, or should we step back and really evaluate them stopping all of their substances that are of concern? The brain. So as we know, substance use disorders are chronic brain disease. And a lot of times when I share that with my patients, they may have sort of a negative connotation. Gosh, I have a disease. Well, I think it's a positive because then we can develop treatments, right? And insurance actually covers treatments for these individuals, just like cancer being a disease. So as you all know, the model of addiction and how the brain works with regards to addiction is very complicated. And one thing we know for sure is that these circuits do not differ by a specific substance. So there are different systems going on here. The first system is the binge intoxication and reward system. There's a negative affect withdrawal and anti-reward system. And there's a cognitive control and then executive functioning system. I think it's a little bit complicated for all of us and for my patients. So a lot of times I explain it in meanings that maybe make more sense to myself and to my patients. So we all experience distress, emotional and physical distress. Now, looking at the combination between substance use and mental illness, individuals who have mental illness with anxiety and depression and trauma are more likely during their week, their day, their lifetime to have more of these distressing moments. And so what's common in this cycle of addiction is we have a distress, and then we have an obsession or a thought of maybe how we're going to get rid or tackle this emotion or physical distress. And then comes the ritual, right, of what someone did in the past to get rid of that distress. Maybe it's that they drove to the liquor store and got a bottle of wine. Maybe it's that they went into their pantry and got a ton of food to set on the couch. And then there's the behavior, the actual use of the substance or the food. And then next comes the shame and guilt. I shouldn't have done that. I don't feel very good. What is this going to lead to? And then comes the resolve. I'm not going to do this again. I'm never going to drink again. Tomorrow's a new day. I'm never going to do this again. Where we differ between individuals that have substance use disorders is that likely the next time this distressing emotion or physical sensation comes back, we go through the same addiction cycle, the obsession, the ritual, the behavior, the shame, and the resolve. Where an individual that does not have a substance use disorder, the resolve of I'm not going to drink again lasts a lot longer than someone that has a substance use disorder and has the disease of addiction. Where it becomes very dangerous when we develop this brain disease is when the distress and emotional or physical distress goes right to the behavior of using. And we skip the steps of the obsession, the ritual, the shame and guilt, or the resolve. We're going straight from the distress to the use and then back to the uncomfortable feeling or emotion. And that's where the automatic of addiction comes in. It's completely automatic. And we know that circuitry is occurring in the brain, from the distress, the emotional and physical distress, to the use. And that's why treatment is gold standard, because we need to remove someone out of that environment to start to walk through the steps again and really work through the shame and the guilt and the resolve. And so looking a little bit more about the brain, one important thing for us all to know is that the prefrontal cortex is one of the last parts of our brains to develop. And this is why it just saddens me that substance use is occurring for individuals that are younger, because their brain is still developing. And that's just why education needs to occur in schools at younger ages, so we can really have a positive impact. One particular part of the prefrontal cortex, which is involved in executive functioning and decision making, which is not fully developed, 20, 25, some people even say 30, maybe for males, no, but 20, 25. A part of the prefrontal cortex, the executive functioning, it's called the orbital frontal cortex. And what that part of the brain is it's the pause or the brakes prior to making a decision, which to me makes a lot of sense in addiction medicine, because that part of the brain, the orbital frontal cortex, that's the pause or the brakes prior to making a decision, is not active when someone is active in their addiction, and even early in recovery, first 3 to 6 months, which is key, and we'll talk about that later. So if that part of the brain that pauses or breaks prior to making the decision to use again is not active, and our individual patients are returning to these same environments, same triggers and cues, it's a lot harder for them to think through the consequences and choose to make a different decision. It's why back in the day when we would say that it's a choice to continue to use, we know now with the brain, it's not a choice. It's that automatic action where individuals aren't really able to think through the consequences. And when they've done MRI scans of the brain, when individuals are 8 to 12 months into recovery of their substance use disorder, that part of the prefrontal cortex, the pause or the brakes prior to making a decision, starts to light up again. It becomes activated. So people are more adept to be able to think through when the last time I drank, what happened? Oh, these are all the consequences that occurred, right? Or if I return to this environment, this is likely to happen again. And that's why a lot of people say after that first year of recovery, you're able to return to situations and maybe triggers and stressors that would be very challenging early on in recovery. That's also why the medications that are approved for substance use disorders are approved during the first year of recovery. And that's not random. That's because it takes about 8 to 12 months to allow our brains to heal from substance use disorders. That's why we, at Vanderbilt advocate after detox and stabilization that people go to treatment as much as possible, are in sober living, and are in environments that are conducive to their brain's healing. And so going back to, again, some predisposing factors for why individuals develop substance use disorders. So this is just looking at risk alleles that researchers have found that are likely to be shared among individuals with family members that have substance use disorders. So here we're looking at alleles, the first one having more to do with serotonin, the DRD2 having more to do with dopamine. We know one of the biggest releases of dopamine in the brain is methamphetamines. The third being opioids, and then looking at the fourth with regards to long-term potentiation and learning effects. So having to do with, again, the stimulant medications. And again, to me, when I talk to my patients, it takes a lot of the shame out of it. There's a reason why we do what we do, and there's a big hereditary factor. Now, it's not an excuse, right, for not seeking treatment or reaching out for help or going through the recovery journey, but I think it diminishes a lot of the shame of why me. I've never met a patient who developed an opioid use disorder that the first time they took an opioid, say maybe in childbirth, they started vomiting, becoming so sick and agitated. that's not the person that develops an opioid use disorder. The person that develops an opioid use disorder, the first time that they use an opioid, a lot of times they feel a sense of relief. They feel normal. They feel like they can take care of their kids, clean the house. And that makes sense to me with regards to, again, the predisposing factors of their brain being different from someone who takes an opioid and has a very different reaction. So again, looking at that strong hereditary factor. And then again, the example I gave with regards to dopamine levels in the brain, those people are more likely to develop a substance use disorder to actually fill that need in their brain and their body. And so the gateway hypothesis has been around since about the 1970s. And mainly it talks about early experimentation escalates to more use, especially looking at alcohol and tobacco, that it primes the circuitry of the brain. We know this to be true, especially when substances negatively affect parts of the brain or the brain circuitry. And again, looking at those models of when our brains are developing to change those pathways so early on, we are really having to change the way that we treat substance use disorders when individuals have developed them so young, and their ways of thinking about them and the way their brain chemistry has worked, a lot of times we're maybe seeing for the first time. And that's why preventative education is so crucial. So these are just showing, again, what different substances can lead to a lot of times. And then looking more at neurodevelopmental and common factors. So as we all know, ACEs, which is adverse childhood experiences, affect the risk prior to first substance exposure, right? Someone who's experienced something really traumatic, they're more primed to treat that, right? Treat that trauma that's in their body. Again, talking about trauma being an activation of someone's nervous system. Also, uneven maturation or development of someone's limbic system of their brain, their emotional system of their brain before the prefrontal cortex, right? We're thinking teenagers. That leads to risk-taking. And then again, the increased risk of individuals less than age 16. You know, we're seeing ages 10 to 13 having dependency on substances and requiring treatments at those ages. One thing, knowing this, I always speak to my patients to talk to their kids about their substance use disorder. And it's really never too early, because you really want to take the shame away from it. You know, hey, I developed generalized anxiety disorder and I lost my job and things were, you know, occurring in my life that were stressful. And I started drinking because drinking really helped calm down my mind and help me sleep. And I developed a dependency on it and I needed to go to treatment. And telling that to the child that since I developed an alcohol use disorder, you're more likely to, because there is a huge hereditary component, and really taking the shame out of it, I find to be very helpful and just strengthens that relationship between parent and child, that there's that open communication. And then treatment of common factors, focusing on shared symptoms. So again, maladaptive coping. So learning early on skills to cope that work. Unfortunately, a lot of our young ones maybe see older peers or sometimes parents that we do the best they can, but are not coping in the best ways possible. And kids pick up on that and they learn that, right? Maybe if mom is very anxious and she chooses not to eat all day, or again, dad had a really stressful day at work and he comes home, and just knowing that if he starts drinking. So learning those maladaptive coping skills at a very young age. And then craving management. So I talk to my patients a lot about cravings and what are cravings. And we know that craving is actually a release of dopamine in the brain. It affects your brain. And so really focusing on, what am I really craving? And talking to kids, what are you really craving? Am I craving alcohol, the taste of alcohol? Or am I craving feeling calm when I walk into a social situation? Or am I craving a good night's sleep? So really looking at, what are we actually craving? And then this graph looks at the lifetime overlap of substance use. So over 90% of individuals with opioid use disorders have at least 2 other substances that they've used in the same year, which is very high. Over 25% had 2 other substance uses. And this group is more likely to be young, male, single, with early initial use. And that's a real common theme, is early use. The active use of one substance increases the likelihood of co-occurring use. And we're seeing this in the hospital very regularly. Someone comes in with an alcohol use disorder, but they're also using cannabis and cocaine. Unfortunately, the dealers and the cartels are lacing a lot of these substances with even more addictive substances to get people hooked. When I worked in Washington State, individuals were offering free opioids when someone was coming to get stimulants, free opioids to get people hooked. So they're really utilizing this statistic against us, and it's causing huge health complications when individuals are using multiple substances at one time, and it can be more challenging to treat. And so why do individuals use multiple substances? Substances, you become dependent on them, right? So if someone's offering you one, especially an opioid, alcohol, and you realize, hey, this works for this symptom that I'm needing. You know, I was actually feeling a lot of back pain and someone gave me this opioid and it's actually really working for me. But now I'm really tired and I feel like I can't function at work. Caffeine's really not doing it for me, but someone, you know, offered me some cocaine and that seems to get me going and allows me to stay up and be with my kids. So again, those synergistic effects of using a downer and then also needing an upper. It makes a lot of sense. I think a lot of what we do and what our patients do and loved ones do makes a lot of sense. And we find fast ways to fill needs. I see this a lot, especially in our society nowadays. People have a hard time being uncomfortable and sitting still. We all do, we're human. But now it's become the norm of finding an easy fix, whether that's a substance, a food, a person, and then that can create more complications because maybe people don't like the effects after they use, and that leads to another use of maybe a different substance to get the opposite effect. So looking at the compensation for undesired effects of another substance, so reported heroin to cocaine cross titration, that's what I mentioned as well, balancing out those effects. Compensation for negative internal states, again, makes a lot of sense to me. Someone that comes in that has major depressive disorder and they're using stimulants to try to give themselves some energy. The self-medication hypothesis, again, people with substance use disorders are smart and we find fast ways to cope. I'm anxious, I'm going to start drinking alcohol. I can't sleep, I'm going to use a lot of Delta 8. And then the PTSD co-occurrence associated with the use of opioid use disorders and at least 2 other substance use disorders. PTSD being one of the primary mental health conditions that I see with individuals coming in for treatment. Trauma is everywhere. And I think it's so important to address what's happened to us at any point in our life, because if we don't address it, when we're a kid, when we're an adult, it's going to continue to follow us. And then even as an adult, if I didn't address what happened to me at 10 years old, maybe I'm going to be treating that Jana as a 10-year-old with different substances. Very, very common. And we'll talk about other strategies besides medications that can really help treat these mental health conditions. And then another reason for co-use is we know that individuals are more likely to be exposed to other substances with the environment they're in, right? Other people are using, other people are saying this helps me, this doesn't help me, and just trying to feel better, really trying to survive. And And then looking at synergistic effects, Dr. Finlayson is brilliant. He could explain this whole graph to you. Substances definitely change our brain chemistry significantly. Unfortunately, some occurs in the short term, and some brain chemistry stays altered in the longer term as well. The example I gave before, again, meth has a huge release of dopamine in our brain and body. And so what that causes then, if we become dependent on one of these substances that inundates our brain and our body with dopamine, our bodies are super smart. And so they're going to stop their natural production of dopamine or these positive endorphins, which makes a lot of sense. Our body's not going to work any harder than it needs to. However, then when I remove the meth or I remove the alcohol or whatever's causing an outside source of dopamine, my body and my brain is struggling. I may feel depressed, not wanting to do anything, anxious, trouble sleeping, because my internal system is not working. And because of that, I'm likely to return to use, right? Because I want to feel better. And so that causes a need to continue to use substances because our body is stopping its own actual positive productions of endorphins. I saw this a lot when I worked with an OBGYN, right? And during childbirth, some individuals that are given large amounts of opioids, and it actually stops the pregnant woman's ability to produce her own pain chemicals to deliver the baby. So it can counteract each other. And then the pregnant woman requires even more and more opioids for labor. And so this is summarizing that kind of some of the synergistic effects and the cravings. But as we know, patients and your loved ones, we figure out what works for us, works for our patients to treat their symptoms or cope with a feeling, and it all serves a purpose. And that's one thing I really work with individuals on, is what is the purpose behind it, and then finding different ways to fulfill that. If cocaine is someone's energy, if it's someone's friend, we look for connection. Other ways to get that dopamine in the body. 3 of the biggest ways that I see that individuals can get dopamine in their body and their brain without substances. 1 is having purpose in life. That's huge. That can be big. The second one is service, serving others. And that can be someone's purpose in life. Serving others can be great, like being a sponsor. It can be helping a family member or a friend. It can be giving a compliment to someone. And then the third biggest release of dopamine, which was devastated during COVID, unfortunately, is connection. Human connection has that huge release of dopamine. And if we don't have that connection and that big release of dopamine in our bodies, we're human beings. We're going to find it in other ways, whether that's drugs, alcohol, sex, gambling, unhealthy relationships. So connection, purpose, and service. Those are 3 principles I really work with my patients to cement so that they're less likely to need substances to fulfill that dopamine release in their body. And then looking at some of the negatives when people use multiple substances, opioids, and then any benzodiazepine. So benzodiazepines are Ativan, Xanax, Valium, Librium, Klonopin. We're seeing a huge increase in the number of overdoses and deaths when these 2 medications are combined. Thankfully, a lot of states have done work to look at the prescribing of these medications. We have controlled databases where if you're prescribing a controlled medication to a patient, other prescribers can look that information up to ensure that that patient is being properly cared for. One thing I did want to mention, another increase in the overall deaths with opioids and benzodiazepines is something called xylazine. We're seeing it come from the East Coast and it's making its way now into Tennessee. I've seen a lot of cases in the past couple months. Xylazine is a sedative hypnotic. It's a depressant. And unfortunately, it's being laced with fentanyl. And so individuals that are using xylazine aren't aware of it. They believe they're just using fentanyl, the really potent opioid, and their withdrawals, if it doesn't unfortunately kill them with regards to overdoses, their withdrawals are really brutal. If they inject into their arms or legs, it causes blood to not be in that area. And so individuals develop wounds that need to be cared for. There are a lot of individuals that are needing amputations because xylazine is mixed in with this fentanyl. And then the withdrawals that we see, Dr. Finlayson and myself on the inpatient unit, is severe anxiety when they walk into the emergency department, when they're on our unit a week later, withdrawing from opioids that cannot be managed, they feel like. Unfortunately, that's one reason a lot of loved ones are leaving treatment, because this anxiety is so high. So we've developed different strategies, and really now I've started to treat most of my patients that come in using fentanyl, thinking that they have xylazine mixed in with their fentanyl, because I want them to stay in treatment and I want to ensure that their anxiety is managed. But I think that's an important point for us to recognize in the community, that xylazine is making its way down to Tennessee, unfortunately, and really having a devastating effect, not only on overdose deaths, but also on the severity of withdrawals and individuals then leaving treatments. I'm so glad to be back in Tennessee and working at Vanderbilt, but we struggle with substance use disorders and treatment here. And it's something I'm really passionate about advocating for. Again, looking that it takes about 8 to 12 months for our brains to heal. We need to have treatments that support that healing of our brain. If we've been using substances for over a year, and we think that we can treat substance use disorders in 3 days in detox, in 10 days, or in 30 days, we're just not being honest with ourselves. It takes a lot longer for these individuals to stabilize. And because of this, we're seeing individuals leave treatment, and the rate of overdose is just skyrocketing. Their tolerance decreases when they come into detox or when they go to treatment, because they're not using substances, they're not used to that amount of medication in their body. And unfortunately, treatment is too short, especially in the state of Tennessee, and that's leading to intense number of overdoses. And as you can see here, the rate of benzos and opioids that are involved synergistically together with regards to overdoses. Benzodiazepines, as y'all are aware, are clinically prescribed for short-term use for anxiety. We've done ourselves a big disservice with prescribing these for long-term anxiety, because it actually makes an individual's anxiety worse when they come off of it, which just devastates me for my patients, thinking that this individual had a panic disorder, a generalized anxiety disorder, and they took Xanax or Ativan as prescribed by their doctor for years. And it helped at first, right? It helped at first with their anxiety. They became dependent on it. And then when they stopped it, they developed hyperalgesia and hyper anxiety in their body and their brain, because it completely changed their whole structure of their nervous system and their brain. So these individuals had higher anxiety prior to taking the benzodiazepines. And then after, their anxiety is even more escalated than someone that was not using benzos. And hyperalgesia goes with opioids, not with benzos. Hyperalgesia with opioids indicates that someone who was prescribed opioids for pain, right? They had real pain and they were prescribed opioids. They took them as prescribed, and then they stopped them, and their pain, emotional and physical, was more severe than someone who was never prescribed opioids. It's just devastating. We do have treatments, but these medication, opioids and benzos being prescribed long-term, does not benefit our patients. It puts them at an increased risk of using, and ultimately an increased risk of overdosing. And so this is looking more at the detrimental effects with regards to substance use disorders. We know alcohol being one of the highest causes of motor vehicle accidents and unintended injuries in the United States. And then comorbidity, rule rather than exception. I definitely believe this. This is why I think it's so important that our loved ones and our patients go to treatment or involved in support groups, experience the support like NAMI provides, and go to 12-step meetings to realize that they're not alone, they're not crazy. Connection is so the opposite of addiction. and realizing, oh gosh, you were anxious too, and you had panic disorder, and you became dependent on alcohol, so did I. Or you had 5 kids and it was hard for you to get through the day. You felt exhausted. Someone offered you cocaine and you became dependent. So did I. Really to realize we're more alike than we are different. And that occurs definitely with regards to someone who has a mental illness, developing a substance use disorder and finding that connection in the community. And so this again is looking at adults 18 or older and the prevalence between serious mental illness, any mental illness, and the high rate of substance use. It makes sense to me. It makes sense to me. And then here looking at co-occurring in the past year of substance use disorders with any mental illness or a serious mental illness, you can see the very vulnerable group. Ages 18 to 25. This is a very vulnerable age, as we know, individuals finding out who they are, what their purpose is. And unfortunately, substances can fulfill this in the short term, right? If someone maybe is lost with regards to connection, work, relationships, spirituality, life, this is really where substances can come in and have that purpose fulfilled in the short term during this very vulnerable age group. And so this, again, looking at circuitry in the brain, really with regards to any substance, it's reinforcing patterns in the brain. And this is why treatment is so necessary. This is why treatment is so necessary. And this is what I tell my patients on a daily basis, getting out of that environment and really learning new ways to deal with cravings and uncomfortable emotions, and then reinforcing those pathways in the brain. Taking about 8 to 12 months, like we know, for the brain to heal, but it gets better every day. The next. And then unfortunately, right, with comorbidity, we do have worsened outcomes because these individuals are more susceptible to higher relapse rates, higher acute care use, more medical complications as well. Huge with regards to social determinants of health and being able to access these resources. And then the huge challenge of non-integrative care, which we hope to continue to have a positive impact in the state of Tennessee. I worked at the methadone clinic in Washington State, and I loved it there because not only did I see individuals and was able to make a positive difference in ensuring they were on an adequate dose of methadone, which is a stabilizing medication for an individual that has an opioid use disorder, but I was also then able to see that patient later in the day to look at their mental health needs. How are they doing? How are they sleeping? Were they eating? Tell me about your anxiety and your depression. I was able to meet with them and potentially start medications. Unfortunately, in Tennessee, it's completely non-integrated. Methadone clinics do not have any psychiatric care right now associated with them, and hopefully that'll change in times to come. And methadone clinics just being one example. We need more integrative care with regards to looking at the individual's medical and substance use disorders and psych illnesses. And this is always very interesting to me. So substances induced disorders, very, very difficult, I think, for any practitioner to assess whether the substance created the mental health condition, did it potentiate, or are they completely separate? Unfortunately, in the inpatient world, I don't have a lot of time to uncover that. What I tend to recommend to my patients that are in the outpatient world is to have 90 days of sobriety, 90 days of not using substances, which I know can be a big challenge, but utilizing 12-step groups, support groups, family resources, so we can really see what someone's baseline mood is. And then it's also important as practitioners to not jump to conclusions, right? If someone is using methamphetamines and they come in and they have paranoia, psychosis, they're not acting their normal self, to diagnose them with schizophrenia and put a label on that patient would be doing them harm. Really looking at how long were they using the substance And then again, what was their mood like during their most recent period of sobriety, and talking to family members about that. So looking at the actual criteria for substance use, it's an onset within 1 month of use, and that independent disorder is not present prior to use. And then the persistent symptoms do not continue on for about a month. Now, again, there's a lot of leadway here talking about especially psychosis, substance-induced psychosis. Unfortunately, we're seeing a huge rise, especially in young males, early 20s, that are using stimulants, and we're seeing cannabis with high THC potency that is inducing psychosis. And the determination of whether it is substance-induced psychosis or an underlying psychotic illness takes a lot of time. But again, that education early on is so important to our loved ones, that if they have a family member that is more prone to, say, bipolar disorder or has a psychotic disorder, if they use a substance, it could potentially precipitate that. And then we never know. We never know if that individual's psychosis or paranoia is going to dissipate after they stop using the substance that maybe precipitated it. We don't know. Patients that I saw in Washington, it could take up to a year for their psychosis to resolve. And it was just devastating for families. So it's always a hard line, right? If someone comes to me, most of my patients who are dependent on alcohol, they're depressed when they come to see me and detox. They're depressed days after they stop drinking. Of course they are, and I normalize that for them. They've been using the biggest depressant out there on a daily basis. And then we know that they've been depleting their whole dopamine system. So normalizing that for them. Does it mean they don't have major depressive disorder? Maybe not, but it's normalizing that and really assessing what's their baseline mood without a period of substances. So again, kind of reinforcing, is this primary or secondary? We know chronic opioid use is associated with depressive symptoms, makes a lot of sense. And then post-acute withdrawal can again be a lot of times misdiagnosed in individuals. Again, someone using methamphetamines and they're agitated, they're not sleeping, they're having anxiety. Of course they are, and that's going to take some time. And that's why it's so great in the hospital that we can help stabilize them and then see their baseline. Unfortunately, sometimes labels are put on these individuals, right? That they have a severe mental illness, and sometimes the treatment can be more harmful than just giving them some time, but it's really all independent on the case. And it's something that is really important for providers to talk to families about and really learn about the individual's mental health state prior to using substances. I have a little bit of a different philosophy since my focus is addiction medicine with regards to mood disorders. I find that a lot of times it's on a spectrum. And that's what I work with my patients on, not putting such a sharp label on it, but understanding why they may have developed depression, or maybe they're more prone to having some hypomanic episodes with bipolar disorder. And again, not labelizing, but understanding what precipitated potentially this mental illness, predisposing factors, what's continuing to maybe have them have depressive symptoms on a daily basis, such as substances or poor sleep, and then really focusing on what are great protective factors that these individuals with mental health conditions to use to stay in recovery. A lot of times it can be medications, in addition, again, to connection, to purpose, and having service in their life. And so these are just some examples that Finlayson picked with regards to what we would ask individuals with regards to their substance use. Always want to look at what's a period of time where they weren't using substances, and not judging, right? Not judging that this individual is psychotic or they're lost and no hope for them. I always see that there's hope because there's treatment out there. And so diving in a little bit to treatment of co-occurring disorders, and there's a lot of debate out there, right? With regards to someone having a mental health condition and a substance use disorder, which one do you treat first? We find that someone has to be medically stable. That's really important. And you want to ensure that you treat each with the best treatments possible, the best individualized treatments. So treating the mental health condition, and if we can, concurrently treating the substance use disorders. Again, knowing that a period of time without substances may change their presentation of what symptoms they have of their depression or their anxiety. I find that it's really hard to treat one without the other, but then you have to meet patients where they are, right? So if someone's really wanting to focus on their depression, but they're not ready to stop drinking, okay, let's focus on the depression. And I want them to continue to come back and see me and come back into care. That way I can have that impact to do some motivational interviewing to look at their alcohol use, but always meeting the patient where they are if they're not ready yet. And then avoiding benzodiazepines. Dr. Finlayson and I are on the same page as that. Again, short-term use, the only time I prescribe them is when someone maybe gets on a plane and they cannot fly home from treatment. They need an Ativan. I want them to get on the plane and go back to see their loved ones, but really short-term use, especially with our individuals with substance use. And then in addition to medications, there's a lot of great options for treating co-occurring disorders. We use CBT most frequently in co-occurring disorders. And then we've started to use motivational interviewing a lot more, especially on the inpatient unit. Again, really meeting the patient where they are is so important. I love what I do. I feel like I have a lot of knowledge of addiction medicine, but I don't know the patient better than they know themselves. And so I really want to understand their goals, their values. What do they want out of treatment? What do they want when they're here in the hospital, or what do they want in their recovery? And really pulling those values out of them and focusing on what they want to get out of working with me and addressing their co-occurring disorders. But there's a lot of great therapy out there. I think the hard part right now is finding those individuals. And that's why a group setting can be so valuable. And finding those sponsors, finding those individuals that can help mentor you, in addition to if someone is fortunate enough to find a therapist that maybe specializes in the therapy that would be most beneficial to them. And so just looking again at the whole picture with regards to treating the individual, treating their cravings, their substance use, and their mental health conditions, also always involving the family and their support networks. So really looking at the entire picture and setting someone up for success. I don't treat a patient without ensuring that I talk to an outpatient provider or a family member. I just want to learn as much as I can about this person, because we're all complicated. And again, going back to the beginning, there's a reason why they're here sitting in front of us. There's a reason why we develop substance use disorders and why we're maybe more prone to mental health conditions. And it's really important that we take a step back and really reflect on why this person is seeking treatment and what are the best strategies that we can use to help support them in recovery. And so that's kind of what I have for the talk today. Just in summary, again, looking at huge prevalence, right? Individuals that have substance use disorders also have co-occurring disorders. It happens, but I see it to be a lot more rare that someone comes in for straight detox. But it does happen. Again, reason why we do what we do. Most common depressive and anxiety disorders, always looking at the timeline and risk factors. What are the predisposing, precipitating, potentiating, and then what are the protective factors that we can really focus on in their recovery? And then again, not to place judgment or stigma on a person coming into treatment, really understanding what is their baseline mood without the substances, using an integrative approach and having really individualized treatment for our loved ones, ourselves, and our patients. So that's it for me, and I'd love to take some questions.
That was just terrific. Thank you. And and you can either ask a question in the chat. We'll try, since we have many people on here, it may be hard to see your hands raised, so it might be easier to see something show up in the chat, which Don is monitoring. So if you'd like to do that, I think that would be helpful. You can try raising hands, and we'll try to catch you that way too. But just in case we don't, does anyone have any questions? For Jana. I'm while you're thinking about what your questions might be, I am going to say your passion and compassion come through. And for us as family members, as people living with these conditions, as professionals, I can't tell you how much we appreciate that. It's so meaningful to us. You had mentioned, and like I said, if you've got any questions, put them in the chat. I'm going to chat a little bit, but I don't want to chat over anybody that has a question. But I am going to bring up some things that, some points that I noticed. We're finding that finding a therapist these days can be very difficult for people. And we know there's a long wait, or they don't take insurance. We understand why, but it still is very difficult on people who are trying to get the help. That is an issue, definitely. And one thing that we always find interesting, because we lean more towards the mental health side. Our partners, TADIS, the Tennessee Association of Alcohol and Drug Abuse Services, are our counterparts more on the substance abuse side. And so what we observe, and I do see that we have a question, so I'm going to go to that in just a second. What we observe is that on the mental health side, there's a lot of HIPAA, a lot of, patient focus and centered, which we applaud, but not a lot of let's involve the family. And you do have that more commonly on the substance use side. And so that is something we would love to see more encouragement for, while respecting the individual at the center, of the issues. So we've got a question.
And I was going to interrupt you. I'll go ahead and ask it.
Go ahead.
So what happens if the brain does not heal from doing drugs?
Great question. So our brains do heal. Now, with regards to a complete elimination of all symptoms, right? Especially when we look at individuals that are using high potency THC or stimulants, there may not be a complete resolution of psychosis symptoms. That definitely occurs. But with regards to most substance use disorders, our brains heal. They really heal. And how you can support that is with medications and is with treatment and being in a therapeutic environment with good supports. And it takes time, but our brains do heal. Sometimes not complete resolution of symptoms, but they do heal. And I think you all see that too with individuals that are in recovery, right? Mental health and substance use disorders. Those are some of my friends and mentors, some of the most joyful, full of life, high quality of life individuals that I know. And so I think those are really great examples that the brain does heal.
Thank you. Thank you very much for that. One of the things that we definitely have seen since the pandemic is the increase in anxiety and depression. And we have seen individuals that are fighting this battle of the medications for anxiety, actually that dependency, which really creates further problems. And so we know they're trying to avoid the feelings that anxiety brings, but I loved how you consistently talked about the facts, that therapeutic interventions and CBT and thank you again for being so non-judgmental and not labeling. Around here at NAMI Davidson, anything that we deal with around this area, we call it stuff. And everybody's got some. And you know, and it just depends on to what degree you have stuff that you're dealing with, but we prefer to empower the individual and not the stuff they're dealing with. At the same time, getting them where they need to go that is going to give them the best opportunity for healing. But we really appreciate your focus on that.
We have another question from the chat. Where can one find help if they do not have insurance?
Great question. And help with substance use disorders, mental health.
I would think it was not clarified, but I would think on the top.
Yeah, both.
On the topic.
I mean, NAMI is a great place to start.
Yep.
I mean, the more people that you speak with, there are resources out there. We accept patients that don't have insurance for mental health and for substance use disorders, Vanderbilt. So really, if you are in crisis, I mean, first option is always to go to any emergency room, and they have great social workers and case managements that can help kind of direct treatment if someone needs inpatient care versus if someone can be successfully treated on outpatient care with a grant program or without insurance. So I would look at organizations, and then again, if crisis, coming into the emergency room, and that can be for a lot of people a great place to start.
And so what I'm going to add to that, thank you, Jenna. I'm going to add to that we have a 24-hour walk-in crisis unit, as well as Vanderbilt has resources. And we like getting folks into there if they're not in medical need of an emergency, if it's primarily substance use disorder or mental health issue, because sometimes they may end up waiting in an emergency room. But 250 Cumberland Bend is the crisis treatment center at Metro, and you can walk in 24 hours a day if you are having a crisis. Tracy, would you share a little bit more about what you have there at Vanderbilt, please?
Yeah, I was going to also mention that we have a intensive outpatient program. In addition to our inpatient program, we have an intensive outpatient program for co-occurring disorders. So that's another treatment option. And sometimes people might go into detox and step down to intensive outpatient to lengthen the length of treatment that they mentioned that was so important. And the other thing I just wanted to mention while we're talking about it is I think language matters in this case. And we like to say, you know, people with substance use disorders versus things like they're an addict or they're an alcoholic. So I think that helps, help reduce the stigma too and help folks seek treatment. I think we need to remember that as well.
Thank you, Tracy. That is so very important. And then the other thing that I will say is to the question, where can you find help if you don't have insurance? Contact us at NAMI. We know the resources in the area. We and there a lot of it depends, what's your income. And we have a new resource that we have been told about that we may be able to direct some folks into. It's a limited resource, but we have some access to some limited things that we may be able to share, and it's all dependent on what your situation is. We don't do an intake specifically, but we've got some pretty good knowledge, based on what you're dealing with, and it can be hard. I think, Jenna, one of the hardest things that we see is when somebody who's been fighting something for a really long time and finally says, I'm ready, and that there's no place for them to go. Mm-hmm. That is so hard. Now, we do work with TADIS. I mentioned them before. This is the Tennessee Red Line, and that is our sister organization in substance use disorder. And so we work with those guys. They are to substance use what we are to mental health. And we work with all other groups and a lot of other groups in the county, but I just don't want any of you to give up. Don't stop fighting. It's hard, but don't stop. And Jenna, I love your your love for people and saying and saying that you want to find the underlying factor. There's a reason people do this. And it reminds me of juvenile court here, when instead of asking, why did you do that? Instead of asking that question, they ask, what happened to you? And so that can be a much better question. What was the situation surrounding it, rather than pointing the finger at the person? And so Don, I see we have two more questions. One is, what is the limited response, Robin, and the resource? We do have a private resource that has been brought to our attention that only opens a portal every once in a while, and it is for people. It's a brand new resource, and it is for people who may already have insurance, may already have insurance and just haven't been able, they might work for a big box store and just have a really high deductible. So they may have insurance, but it doesn't cover things that well. If you are somebody that wants to know more about this, reach out to me, call the office. And Don, if Don will list our number, you'll get to our helpline, and then they'll get you to one of us.
Exactly.
The other question that Darla said is, what do you do when somebody is kicked out of programs time and time again, and they say you can't? Don't give up. Don't give up. Now, I want to say to family members, maintain your self-care to family members. That's really, really important. Just make sure you're also doing your own self-care. And the other thing is, whose recovery is this? You know, it's that's something that we also share. So I really thank you, Jenna, for doing that. I'm going to stop talking for a moment to see if anybody else has any comments or questions. And I want to just do a shout out here to Jess Walker, who is on here tonight. Jess, you want to say hello? And Jess has been with us for years with NAMI at Vanderbilt, and I know this is a subject that's near and dear to her. So
yeah, thank you so much, Robin. I was trying to remember the number of years now, but I've loved all of the years, however many they are. And I also, it's great to see Jana, because we worked together in the past too. And so I'm so grateful for all of her work and all she's doing for the community. But great to see everyone tonight.
Thank you, Jess, and we appreciate all that you've done. Joan, I still see a hand up. Was that for the question that you already asked, or did you have another one?
I have a question for Dr. Briggs.
And what was your question?
Dr. Briggs, my question is for you. And I was struck. First off, I want to thank you for your great presentation. And I also want to thank you for being of service in the community for those with psych disorders and substance abuse issues. My question to you is, I'm intrigued by how you got into this field and where your passion comes from. Is there somebody in your family that was affected? I'm just curious about how this has come about.
Yeah, thanks for your question, Joan. First off, I'm really interested in the brain and addiction medicine. And then I have been around a lot of individuals that have been in recovery and have such a high quality of life and have even more joy than even prior to their recovery. And so I've always been interested in that progression and helping someone through the detox and to get into recovery. And then I had one of my close cousins was born dependent on heroin back when heroin was a thing and not fentanyl. So went through neonatal abstinence syndrome quite severely. And so that's where my love caring for pregnant women dependent on opioids came from. And I just love it. I just have such a joy with it. And, you know, I'm glad it came across that Robin said, there's a reason we do what we do. And so, you know, meeting people when they come in and have crisis and helping them really navigate, you know, what's been going on, what's happened, understand it, and take a lot of the shame and the stigma, and to recognize we're all human. I really enjoy it. So that's a little bit about why.
That
Well,
definitely
thank you,
comes across.
because you know, I'm a bit of a cynic, and I always think, well, normal people really can't understand it. And but you seem to really do understand it, and so yeah. So anyway, thank you.
What I always say, Joan, is to my patients is normal is just a setting on the dryer.
Thank you. I so agree with that, Jana.
Yeah.
You know, what is normal?
Mhm.
And the other thing is, for those of you that are struggling, you may look at people and think, oh, they're so put together. You know, everybody's so put together. It's not true, guys. It really isn't. You know, maybe they don't have the depth of problems that you do, but nobody has a perfect life, and we never know what's going on in the background with someone. And so, you know, do keep that in mind. And so we are, we're closing in on our time, and I realize, Philip, that you may have a question. I do want to, you know, get a couple things in. Don has listed in the chat the Tennessee Red Line number, the 24-hour for the Tennessee Red Line, and our weekday information and referral line, our health line. And so we do have those. We have time for a brief question, because I do want Don to share the supportive things that we have coming up in the next week. We always update you on whatever support groups that we have. And thank you for your reference to making sure, Jana, one of the things you kept stressing community and purpose, and having a purposeful life, no matter how that's defined, and you get to define it, really makes a difference. And then having someone to share that with in some way also can make a difference. And it doesn't have to be a large group of people. And so we're going to have time. Feel like I'm going to come to you for a very quick question. And then if it's something that can't be answered quickly, then what we'll do is we'll take your information and get you an answer that is off camera. Okay. So is it
All right?
Is it a quick question that you have?
Yes. Quick question. Otherwise, in therapy for treating drugs, you know, the treatment to, you know, get off drugs or whatever, what other treatment plans, you know, do you use?
Besides therapy?
Yes.
Yes, absolutely. So there's medications that treat substance use disorders that provide stabilization. And then also with regards to support groups. So we really recommend individuals find their community, whether that's 12-step groups, Smart Recovery, Refuge Recovery, NAMI support groups. I think really walking with other people that are in recovery and then finding mentors or sponsors is a huge part of treatment. So medications and therapy, and then, yeah, the support.
Thank you. And thank you for the question, Philip. At this time, Don, Jana, I want to thank you. Could we please give her a hand? I think she just did a great job, and great slide. Please give Reed our best. And we're so sorry he wasn't feeling well, but at this time I would like to ask Don to share what we have coming up in the very near future.
Sure. Thanks, Robin. And thank you, Jana, for your presentation tonight. Short term, we have our Friends Supporting Friends group tomorrow night. That is our peer social engagement hour from 6:30 to 7:30 via Zoom. We've been doing this for over 2 years now. It is a social hour that we host the first, second, and fourth Thursday of every month. Next Wednesday, a week from tonight, we are welcoming Kate Ambrosia from the VA. She's going to be doing a presentation on what the VA offers in support to both veterans and their family members. I did want to announce that we have not officially put anything out for registration yet, but we will be hosting a Bridges class for people with lived experience starting mid-October. There'll be more information in my Monday emails coming soon, so stay tuned to that. I did want to, since Robin is here and she is one of the teachers, we have our next family to family class starting in person in August. That is an 8-week intensive course. If Robin would like to fill in more information about it, she can, since she's teaching it. But again, it is for caregivers to learn more about your loved one's mental health issues. It includes crisis planning, communication skills, learning about the brain, learning about different medications, just, you know. And the biggest thing is what Robin said earlier, it's also supportive. You're with people who are going through similar situations, and we have found at NAMI that we are the people with the expertise of living it every day. And the family to family class gives you the opportunity to learn from people who have experienced this before or are still experiencing it, and be around other people who are dealing with similar issues. And again, we at NAMI believe in that community, that support.
Thank you, Don. And I always tell people with lived experience that even though you do not attend the family to family class, it's for you. Send your family members there so they can have a better understanding and they can partner with you better. We have found, we do a pre and a post test to this class, and 80% of the people coming out of this class are better able to communicate with a loved one with a mental health issue. 80% also state that they have reduction of crisis in the home following the class, and caregiving, their self-care is actually also at 80%. So this is an evidence-based national signature program, and it's been a staple with us and has helped a lot of folks.